Medtronic technologies impacted more than 72 million people in the last year, equating to 2 people every second. Harnessing the power of technology to take healthcare further, each technology has unique benefits designed to serve patients. The goal of this program is to get closer to the patient and delve into the challenges and impact of each technology in practice. This is the Medtronic MedEd Learning Experience. No monitoring system should be used as the sole basis for diagnosis or therapy, and they are intended as an adjunct in patient assessment. Reliance on a single monitoring system alone for patient management is not recommended. The contents and conclusions of the following programs are solely those of the speakers unless otherwise cited. The speakers are responsible for all content and any necessary permissions. The speakers receive funding from Covidian LP, a Medtronic company, for this speaking engagement. Medtronic's medical education programs are offered to provide attendees education on FDA-cleared indications and use of our products when applicable. For this segment of the series, a discussion on patient safety in procedural sedation. What are society guidelines for the use of capnography in procedural sedation? To help answer this question, our procedural sedation nurse, Linda Erfle, and gastroenterologist, Dr. Ashish Chawla.
So, Linda, I know that there are many guidelines present for non-operating room anesthesia. Can you tell me a little bit about the society guidelines as it relates to procedural sedation?
Sure. Why don't we go over a couple of the societies first for people who are just listening? So let's go over the societies so for people that are listening can know what we're talking about and who we're talking about. The ASA is the American Society of Anesthesiologists. The ARIN is the Association for Radiologic and Imaging Nursing. The SGNA is Society of Gastroenterology Nurses and Associates. SIR, Society of Interventional Radiology. ESA is the European Society of Anesthesiology. And the ASGA, which is the American Society for Gastrointestinal Endoscopy. So all of these societies, except the ASGA, support the use of capnography in moderate sedation. Ash, why is the ASGE not supporting routine use of capnography in 2023?
You know, Linda, that's a good question. And I think one of the problems that we run into is that the ASGE came up with their guidelines based on data done in the late 90s. So there was a study done where they evaluated the utility, the benefit of using capnography with pulse oximetry versus just using pulse oximetry alone. Now, if you look at that 1990 study, the majority of these patients were ASA1 or ASA2, and these patients had an average BMI that was between 27 to 28. As you realize, this is not our patient population currently. So when they looked in this small subsection, they didn't find a statistically significant benefit. Now, other larger studies after that really do show improved outcomes. Our problem right now is that our current outpatients are just sicker. They have obesity with morbid obesity. They have multiple comorbidities. And also, our cases are just longer. We spend more time. I mean, we spend more time just getting to the cecum because we're required to. We have to hit the cecum in 97% of our cases. We take care of bigger polyps, so the procedures take longer. And then finally, as you know, because you help us all the time in the procedural unit, patients get more abdominal pressure, they can have more retching, they can have more pain, and this leads to a vicious cycle where we give more sedation. And again, this leads to increased risk of respiratory compromise.
Right. We have to go in through the anesthesia continuum where they're going through moderate to deep, back to moderate sedation, because if they're awake, you're not getting a good colonoscopy. And the doctors are always asking for more sedation. And patients are often in deep sedation for this routine colonoscopy and EGD. So without capnography, there's a real risk for respiratory depression during these times.
No, you're absolutely right. I think, you know, in mild to moderate sedation, we kind of hold that as something that's constant. And we have to realize anesthesia is absolutely not a constant. It's a continuum. right? I mean, our patients, when we are scoping them, go from mild, moderate sedation into deep sedation quite a bit. And that can happen more than once or twice during a single case.
Mhm.
Problem is that in real practice, patients are often in deep sedation during routine colonoscopy or endoscopy. And without having capnography there during deep sedation or when they're in that deep sedation phase, there's a real risk that these patients can get respiratory depression. And if we just rely on pulse oximetry alone, we are between 1 to 3 minutes behind in figuring out that they have hypoxemia, that they have a respiratory depression, and it can lead to patient safety issues.
Absolutely. And Dr. Chawla, just look at that last slide. We have to remember that today, 40% of our population is obese now, and 59.6% have 2 or more comorbidities. It's a big change from the late 1990s. So I think we need to do a little work to get them to recognize
I
this.
absolutely think that the guidelines that we have right now are a little outdated and they need to be readjusted to the patient population and to their comorbidities that we have currently.
Well said again, Dr. Chawla.
Please tune in next week for a new segment from this series wherever you find your podcast. This is the Medtronic MedEd Learning Experience. Thank you for listening.